Good afternoon. Thank you very much for the invitation. I'm going to talk on management of dengue hemorrhagic fever during pregnancy. My talk is basically based on our own guidelines. And when we go through the causes of maternal deaths in year 2017, dengue hemorrhagic fever was the leading cause for maternal deaths, followed by the heart disease and the respiratory diseases. So you appreciate that the most of the pregnant mothers die due to medical causes than traditional obstetric causes, which you are very used to. And when we go through the dengue hemorrhagic fever, the risk factors, pregnancy is the number one risk factor for dengue. And in addition to that, if a pregnant mother gets dengue infection in the first or second trimester, mother develop antibodies. These antibodies could pass to the fetal circulation, and after the delivery, newborn carry these antibodies up to 6 months. So if the newborn get dengue in the first 6 months of the life, they behave as if it is a secondary infection. Therefore, the outcome may not be very good. The third scenario is later part of the pregnancy or just after the delivery. If a mother get dengue, she may be on medication like NSAIDs. Again, our outcome may not be very good. When you talk about dengue during pregnancy, we should know the clinical manifestation, but it is more or less same. But the complications more if pregnant mother get dengue, if a pregnant mother get dengue during the pregnancy. And we have to have an idea of physiological changes of pregnancy which could affect the dengue outcome or dengue management. Then the effects of dengue on the pregnancy and effects of dengue infection on the fetus and the neonate. But when it comes to the management of dengue woman is not different to the management of non-pregnant one. So when you go through the effects of physiological changes of pregnancy and the management of dengue, the physiological changes in the cardiovascular system is very important. For example, during the pregnancy, the pulse rate goes up. And what you call resting tachycardia, the heart rate could be around 100. We know when we manage a dengue patient with leaking and bleeding, the heart rate is an important parameter. So this tachycardia could be due to pregnancy itself, or it could be a complication of dengue. The other thing, there are certain systemic vascular changes happen in the pregnancy. For example, during the normal pregnancy, there will be an element of peripheral vasodilatation, which could lead to systemic vascular resistance reduction. This can cause lowering of the diastolic blood pressure. Because of the low diastolic blood pressure, the pulse pressure could be widened. We know narrow pulse pressure is an important parameter when we manage a dengue hemorrhagic patient who is critically ill. But in pregnancy, as a part of the physiological manifestation, the pulse rate could be wide. Therefore, in normal scenario, if the pulse pressure is less than 20, we think that patient is going for kind of an impending shock. But in pregnancy, if the pulse pressure is less than 25, we have to be concerned about it. Then in pregnancy, the impact of maternal position or posture on blood pressure is important. What we call supine hypotensive syndrome in pregnancy. If a mother is lying on bed on supine position, because of the mature gravid uterus, the venous return to the heart can be compromised, can be affected because of the compression on the IVC. So at least 30 to 40% of the reduction could be there. So if you measure the blood pressure, when the mother is in the supine position, it will be slow. Again, that parameter is important when you manage a pregnant mother who is infected, diagnosed with dengue. And then that means you have to measure the blood pressure in left or right lateral position. We know during pregnancy, pulmonary vascular resistance is reduced and the pulmonary permeability is increased. Those parameters are again important when you manage a patient, a pregnant mother with dengue. What happened to the plasma and blood volume during the pregnancy? We all know during the pregnancy, plasma volume get expanded. Sometimes by term, it could be expanded by 50%. That means that there is an element of physiological hemodilution during pregnancy. The other thing, blood volume also gradually increase until term. This is important in pregnancy because blood volume could gradually increase and significant amount of blood could trap in the uterus. So think during the uterine contractions at the time of labor, there is an element of blood coming back to the maternal circulation from the uterus. After the delivery, because of the complete uterine retraction, significant amount of blood, maybe 500 to 750 amount of blood could come back to maternal circulation. So if you get a scenario that the pregnant mother delivered and with dengue, and the platelet count may be 10,000, and if you decide to give blood at that point, you have to remember, you have to have some kind of calculation of amount of blood you are going to give, because you are expecting an amount of blood coming back to maternal circulation from the uterine pool. And a pregnant woman, usually they may not show the features of hypovolemia, even with a significant blood loss. So these are kind of physiological adaptation of normal pregnancy. So if you get a mother who is some kind of blood loss during the with dengue, then you have to consider giving blood without delay. And sometimes the mother may not show any significant symptoms or signs of hypovolemia with bleeding or leaking, but the fetus might show evidence of fetal distress. That means uteroplacental blood flow is affected due to the hemodynamic changes in the mother due to dengue, either leaking or bleeding. So what are the hematological changes could happen during the pregnancy, which is important for the management of dengue? We all know the red cell mass increase during pregnancy. By term, it could increase up to 20%. And I told you that the plasma volume could increase up to 50%. So there's a kind of a hemodilution. So when you check the hemoglobin, do a full blood count in a term pregnant mother, it could be low. It could be low, like hemoglobin 10.5 or hematocrit 30. So think about a scenario, a young lady who is not pregnant. Her hemoglobin is 15 and the hematocrit is 40. And she gets dengue and with leaking. So for her to have a 20% rise of hematocrit, it should be 48. So we are usually, when we think about leakage, we think about high values of hematocrit like 48 or 50. But in pregnancy, if the same lady gets pregnant at the advanced pregnancy, because of the hemodilution, her hemoglobin may be 10.5 and the HCT or hematocrit may be 30. So for her to have 20% increase in hematocrit, it should be 36. So you can't go by the value of 36. You should go by the 20% increase. So that's why it is important to do a full blood count day one. Then we can monitor the hematocrit and see whether there is a rise in the hematocrit, which is important in the management of pregnant mother who is infected with dengue. White cell count in pregnancy, there could be a leukocytosis in pregnancy. So it could be misleading. Usually in dengue fever or viral infection, we expect some leukopenia. This typical leukopenia may not see in the febrile phase in a pregnant mother. So you might think it is a bacterial infection, which is not. Platelet count could be reduced as a part of the physiological changes in the pregnancy. We call it as gestational thrombocytopenia. But usually it won't go less than 100,000. When the platelet count is less than normal, you have to think about dengue. It could be physiological changes, but you have to think about other unique conditions in pregnancy like HELLP syndrome, etc. when you talk about the platelet count, if you are planning for delivery, vaginal delivery, platelet count more than 50 to 6,000 is enough. What happened to the coagulation in normal pregnancy? We all know the pregnancy is a prothrombotic state. That means there is a tendency to coagulation because of the increased coagulation factors and reduced fibrinolysis and increased platelet activity. On the other hand, in pregnancy, if they get infection with dengue, dengue can reduce the platelet count and reduce the platelet activity. So it's difficult to judge. So it is a good practice to do the investigation like thromboelastometry and get opinion from a hematologist. And in pregnancy, usually albumin is low and the cholesterol is high. So those are not much of useful in managing a dengue hemorrhagic fever patient. What happened to the lungs during pregnancy? As the pregnancy advances, the uterus get enlarged. It occupies the part of the lungs, with advanced pregnancy. So the functional residual capacity is reduced towards the latter part of the pregnancy. The respiratory rate could be high. It could be due to the pregnancy itself. And because of the high respiratory rate, they may be having element of respiratory alkalosis with high PCO2 and low PO2. And in pregnancy, the oxygen consumption is elevated. So they could get desaturated easily and they could become hypoxic easily. And if the pH is low, so you have to be concerned. So those are the things which have to keep in your mind when you manage a pregnant patient who is having dengue. So what happened to the kidney during pregnancy? We know during the pregnancy, renal flow, the blood flow increased maybe up to 50 to 60%. So this high blood flow to the kidney causes a true polyuria. So we depend a lot on the amount of urine output when we manage a patient with dengue hemorrhagic fever. Again, in pregnancy, urine output may not be a good marker, and we have to go with the other parameters as well. In dengue hemorrhagic fever, though patient is in shock, the typical thirst which we see in dengue patients may not appear in pregnancy. Those are kind of physiological adaptation. So you have to keep those things in your mind when you manage a patient with a pregnant mother with severe dengue infection. And in dengue, we know there's a spectrum of the illness. It could be asymptomatic or it could go to dengue hemorrhagic fever. When pregnancy, the complications are commoner than simple asymptomatic dengue infection, what we see in non-pregnant ones. We all know the difference between the dengue fever and dengue hemorrhagic fever. Dengue fever means there is no plasma leakage. But in dengue fever, we all know that there are hemorrhagic manifestations. Unique to the pregnancy, bleeding PV could be a hemorrhagic manifestation in simple dengue fever. And just because they are having a bleeding PV, that is not an indicator to consider them as dengue hemorrhagic fever. In dengue hemorrhagic fever, to consider as dengue hemorrhagic fever, there should be evidence of internal bleeding or leaking. Leaking means the objective leaking. And to have a idea about the possibility of leaking, always we should go by the elevated hematocrit, 20% or more than the baseline. That's why I told you that we should do it's a good practice to do a full blood count day one. Then we can get an idea about the rise in the hematocrit. And in pregnancy, because of the hemodilution, we will not expect high HC hematocrits like in non-pregnant ones. So with low HCT, patient may be in leaking phase. When we talk about the natural cause of dengue, there's a febrile phase, critical phase, and convalescence phase, which we don't give much. We don't take very seriously the febrile phase in non-pregnant ones. But in pregnancy, this high fever during the first 2-3 days could be the killer to the baby. So it's very important to manage the temperature, the fever during the first 2-3 days with regular paracetamol, maybe tepid sponging, maybe asking the patient to get a shower. And it's a good practice and safe practice to admit the pregnant one day 1 or day 2, and irrespective of the platelet count. We talk about the fluid management of in dengue. So we talk about the critical phase, and we know there's a fluid restriction during the critical phase, and usually we advise the patient to take either oral or in the injection IV form. That's normal saline. But in pregnancy, the oral intake may be very difficult. They can't drink. So again, though their platelet count is normal, if the patient can't eat and drink, it's good to give IV fluids like normal saline. In pregnancy, how do you calculate the body weight? You have to get the pre-pregnancy body weight as the patient's body weight, not the body weight during the pregnancy. And pregnancy, another practical point is the hourly urine output may depend on the posture, because the bladder and the uterus, because of the position, you may have to ask the patient to change the posture if the patient is not with the catheter. And urine output could be depending on the posture as well. We discussed about giving colloids, and previous speakers, nicely elaborated it. Usually, when we consider dextran, when we realize the PCV is high, like 48 or 50 or 51, but in pregnancy, you will not get those high PCV values because of the hemodilution. So you may have to consider dextran with a relatively low value, like 36, as I mentioned in the previous slides. So you have to have some kind of open idea. When you see high PCV and reducing urine output to kind of a hemodynamic instability, may need colloids without very high PCV. And Dr. Damayanti spoke about the fluid overload. When you see somebody, especially when you get a transfer from another hospital or another ward, so when somebody is swollen and with the generalized body swelling, and if she's having respiratory distress, difficulty in breathing, and maybe chest wall indrawing, we think the patient is overloaded. But in pregnancy, these symptoms or signs could be normal to the pregnancy. So it's little difficult to assess the fluid overload on clinical rounds in pregnancy. So you have to take the other parameters also, doing ultrasound scan, measuring the IVC volume. Those things also should consider rather than just assessing the fluid overload. Indications for blood transfusion. And my two previous speakers, they highlighted the importance of blood transfusion. It's more when it comes to the pregnancy. In pregnancy, as I told you, that the pregnancy, the hematocrit and hemoglobin could be relatively low, especially after the delivery. If they come just after the delivery, there's some kind of a bleeding during the delivery. So during the postpartum period, anyway, the hemoglobin and PCV is low. So as soon as you realize the changes in hemodynamic or urine output, you have to consider blood transfusion without waiting. And sometimes you get patients, day 1, hemoglobin may be 9 or 9.5. Then before going for the complications, it may be a little safer to give a blood and keep the hemoglobin at a safer level, because if the patient starts bleeding, it will be a little difficult to manage the patient. So this low HB and low threshold for the blood transfusion is important practice in managing dengue hemorrhagic patient in pregnancy. And sometimes you get, as Dr. Damayanti correctly mentioned, you get the patient with low urine output without changes in the hematocrit. So in pregnancy, they are more prone to leakage. So the typical increase in the hematocrit you may not see. in pregnancy, they are more prone to leakage, as well as they are more prone to bleeding. So with leaking, you expect rise in the or increase in the hematocrit. In bleeding, you expect drop of hemoglobin and hematocrit. But if both things happen together, which is again common in pregnancy, HCT is normal. So then we have to get the priority, and you have to treat the bleeding with blood transfusion, and you have to treat the leaking as well. Why? What are the factors contribute to the bleeding in dengue? So it could be, one reason is increased capillary fragility, thrombocytopenia, coagulopathy, and liver failure. When these factors are more common in a pregnant one than non-pregnant one, so you have to expect these complications in a pregnant woman if she gets dengue. Suppose you get a scenario, suddenly you get a patient, pregnant one, referred to you, or you are going to see a one with low platelet counts and elevated liver enzymes, then you should not forget that this is a pregnant lady. So there are other conditions unique to the pregnancy, like HELP syndrome. Then in HELP syndrome, the treatment is immediate delivery or termination of the pregnancy. In dengue hemorrhagic fever, we are not going to deliver. We postpone the delivery. So complete management is completely opposite. So in HELP syndrome, you have to look for features of preeclampsia and low platelet count, high blood pressure, and the blood picture might give a clue about HELP syndrome. And if you do the liver enzymes, SGPT, SGOT, both will be high in HELP syndrome patient. Whereas in dengue hemorrhagic fever, there could be a history of fever. And when you do a scan, there will be evidence of leakage, ascites or pleural effusion. And when you do the blood count, when you do the liver function, usually the SGOT is higher than the SGPT. So you need to be carefully assess the patient before you take a final decision. And usually, as Dr. Anand mentioned correctly, we don't consider platelet in our routine management of dengue patient. But pregnancy is a unique situation. Suppose there's a lady pregnant, platelet count is 10,000, vaginal delivery is progressive, and there's no choice, you can't stop it. Then if the platelet count is very low, then you have to consider giving platelet to that one, because eventually it's dengue plus, you are going to use the scalpel at some point. And suppose a scenario that the patient is at term and platelet count is 20,000, and then it's a breech presentation or shoulder presentation. To save the mother's life, the managing team, the obstetrician and the physician and the maybe neonatologist and anesthesiologist decide to go for section to save the mother, not considering, it's basically we give the priority to the mother's life. In that case, if the platelet count is very low, then we have to consider giving platelets at that scenario. Then if a pregnant mother with low platelet count and delivery, and if she's continuously bleeding in spite of giving blood, we may have to consider platelet as a temporary measure. And if we talk about the dengue shock syndrome, we should remember pregnant mothers are more prone to go for dengue shock syndrome unless we manage properly. And we talk about the atypical manifestation like neurological manifestation, myocarditis, encephalopathy, and renal hepatitis, liver failure. These atypical manifestations, again, pregnant mothers are more prone to get this atypical manifestation than the non-pregnant ones if they get dengue. And why these pregnant mothers died due to dengue? One thing is delayed diagnosis or late presentation. So we know that they go to a obstetrician first, then only come to the physician. Sometimes when they go with the high fever, if they do a urine full report, UFR may show few blood pulses in the urine. So they might go in a different direction. So diagnosis or the referral or presentation could be late. But when you go through the causes of death, the not given blood at the correct time was one of the leading cause for death of these mothers. And when we do the lab test, we know the white cell count could be high in pregnancy. So before considering bacterial infection, doing a CRP or if possible procalcitonin is a good practice, because in dengue, white cell count could be high. If mother get dengue during pregnancy, what could happen to the mother? So mother could end up with an abortion, or she could end up with one of the complications which we discussed in previous slides. The other scenario is dengue at term. So you get patients, pregnant mother, POS, 39 weeks or 40 weeks, and they get dengue fever, and dengue antigen is positive. So basically, we have to give priority to the mother's life, and we manage the dengue, and we are not going to do the section considering the baby. And at that point, fetal distress is not an indication for delivery, and we have to give the priority to the mother's life. But people, sometimes we get a 40-year-old POS 40, term mother, fever day 1, dengue antigen is positive, and platelet count may be 280. Or maybe there may be some other conditions like heart disease. So it's a very individual decision. We have instances, then accepting the risk, facing the consequence, doing a section at day 1 if the platelet count is 240. But the guideline, what we say, we just observe. But the thing is, if it's a very complicated one, if she delivers in 4 or 5 days time, with the platelet count is 10,000, we may face difficult situation, but still the guideline says we should wait, we should not go for section, though there are other instances we have took the baby out. And dengue after the delivery. If a mother who was in the hospital get dengue just after the delivery, most of the time it's a hospital acquired thing. Sometimes when somebody with a pregnant mother after the delivery, if she get fever, when we do a urine flow report, if it is, there are lots of passes, we think it's due to a urinary tract infection or infected episiotomy, and forget about the dengue. So the presentation could be late in that case. Sometimes if a pregnant mother, if after the delivery, if they get dengue, patient may be on diclofenac suppository and painkillers, etc. And other thing, after the delivery, usually the hemoglobin and PCV is low. So you have to consider giving blood if they get dengue. And if they go home and get fever at home, usually they don't come back to the hospital. There's a social situation. When they go home, they think that if they come back to the hospital, it's difficult to look after the baby. So they come back to hospital at late stages of dengue, maybe when they are in shock. So then you should have to have an idea about manage the shock patient, like we discussed in the previous with previous speakers. So if mother get dengue, what could happen to the fetus? So there's a high possibility that the baby could die, the fetal death. So managing the temperature, controlling the temperature is one important thing. Oh, other thing is if mother get dengue during the second trimester of the life, she produces antibodies. These antibodies could go to the baby after the delivery. First 6 months, if baby gets dengue, they behave as if it is a secondary infection. The other scenario is the latter part of the pregnancy, just before delivery. If mother get dengue, the baby could get the dengue infection due to vertical transmission of the virus. The recovery, we know when to discharge a dengue patient, but in pregnancy, especially after delivery, when if mother goes home, that she has to do lots of other jobs, maybe social event. People will visit to see the baby. So we have to keep additional 1 or 2 days without taking a risk. We talk a lot about the dengue and COVID in pregnancy now. It happened, and we see these patients. Sometimes we do routine investigation when a pregnant mother comes with fever. So you get positive COVID PCR and positive COVID antigen. So both COVID and dengue can cause thrombocytopenia and elevated liver enzymes. So it could be co-infection. Or sometimes COVID may be a mild thing, and the real infection or the life-threatening one may be dengue. So we have to decide what is the priority. In COVID, we look after we check the oxygen saturation, and we go through the guidelines. And when it comes to the dengue, we look for leaking and evidence of bleeding, and we balance the priority. And people ask about when they recover from dengue, when to get COVID vaccine. It's a very common question, and we don't have a straightforward answer. But we feel that when they recover completely from dengue after 2-3 weeks, when the liver enzymes are okay, when the clinical is okay, when the platelet count come back to normal, maybe worthwhile taking the COVID vaccine. I have lots of take-home messages because it's a different area. Dengue or medical problems are the leading cause of maternal mortality in Sri Lanka. Pregnancy is a high-risk condition for dengue as it affects both mother and the baby. Normal physiological changes during the pregnancy are important to know. Tachycardia and increased pulse pressure can mislead the management of dengue hemorrhagic fever. Low HB, low PCV during the pregnancy and postpartum should be considered in the management. Fetal distress could be a manifestation of maternal hemodynamic decompensation. It's important to control the fever from day one, and as useful to have a full blood count on day one. Fluid calculation according to the pre-pregnancy weight, body weight. Leukocytosis and thrombocytopenia may be normal in pregnancy. Low albumin and high cholesterol in pregnancy could be misleading. Tachypnea and respiratory alkalosis may be normal in pregnancy. Fluid overload may be difficult to assess during the pregnancy. Blood pressure may change according to the posture. Urine output can change according to the posture and may not be a good indicator to diagnose dengue shock syndrome. Dextran should be considered without high PCV, and blood transfusion should be considered even with mild bleeding. We should not miss preeclampsia, HELP syndrome when the platelets are low and the liver functions are high. Platelet transfusion should be considered when dengue positive and delivery is inevitable with very low platelet counts. Dengue during pregnancy and postpartum period could be a late diagnosis or can be a late presentation. Newborn can get dengue from day 1 to day 5 from the maternal infection. Infant gets dengue in first 6 months, could behave as a second episode of dengue. Before discharge, we should consider the social situation at home for mother's safety. Thank you very much.